Hey there, thank you. Yes, so I'm Kara Kikuchi. I'm with Optum, and we're the Quitline service provider for South Carolina and also Missouri and Florida as well. And I manage the training and outreach programs for healthcare providers for Optum. And I want to get through some of the information about that program, but I want to make sure that we move through quickly because I'm really excited to hear some suggestions about how we can improve our connection with people in the public housing communities and with anyone who is referred over from healthcare providers. So that is our big focus, is we want to improve that connection. Once the participant gets referred over, how can we make sure that they engage in the services at the Quitline? And so I'll describe what is currently, what we're doing. So community partners, providers, they refer tobacco users. I think probably everyone's familiar with the methods for that. It could be more direct, like a fax referral or an electronic referral, or more indirect methods, such as giving out Quitline cards or just documenting that you recommend someone call the Quitline through the treatment plans after the visit. And what we're finding is that most of the tobacco users are not actually connecting with the Quitline afterward. And there are really two reasons. One is that the participant is contacted, they answer the phone, and then they decline services for some reason. That's a lower number, so that's less than 8% for South Carolina. The other more common reason is that the Quitline is just not able to get a hold of that person once that more direct referral is made. So we're talking those e-referrals or fax referrals. So South Carolina had looked at this and thought that it would be helpful to engage in a provider training and outreach program that was launched in 2014. And I'll talk about that. I have a couple of slides to go over. And basically what we're doing with that program is we want to emphasize a quality referral. So what that means to South Carolina is that we inform patients of what to expect from their contact from the Quitline. When will they get a call? Where will the call be coming from? What number will show up on their caller ID if it does show up? We want to really encourage patients to take those calls when they come in during their best time that they've selected, and educate them what the services are from the Quitline, what they can get, and then really motivate their patient to keep engaging with the Quitline, keep taking those calls. And our vision for what that would look like would be really just that not only is this type of engagement with the Quitline prioritized by the tobacco users, but also prioritized by those people that can make referrals. So that providers are seeing that, like, tobacco treatment, working with the Quitline is really important. We're going to emphasize this in our treatment plans with our patients. And overall, we want to see a reduction in those declined services responses to the referrals, and then also a reduction in those not reached responses to the referral outcomes. And we want to improve our conversion rates, right? We want that conversion rate is someone who does go from being referred to actually enrolling into the Quitline services. Let's see, so we haven't had any recent changes. So as I mentioned, we started really working on the outreach component in 2015 is when we really started outreach. We have made not any changes in the last 6 months. And then I have a few slides to go over some of what we've observed, some of the data too. So yeah, you have it, thank you. Yeah, so as you can see here, let's start with the yellow, the one in the middle. 12.7% are actually, of those fax referrals, are actually converting over to enrolling in the Quitline. So, close to 13% of those fax referrals, again, are leading to support for those patients through the Quitline services. And then that's with participants who are working with healthcare organizations that didn't participate in our systems change program. The 21% in the orange that you're seeing is with the organizations that actually engaged with our training and outreach program. So we're seeing an improvement when providers are adopting those practices where they're doing, again, what we call the high quality referral, telling participants what to expect, telling their patients when they'll get the call and to make sure they take the call and what benefits they can get from the Quitline. So an improvement when organizations are working toward that goal, certainly. And then I think the slide before that was just showing our program, just overall, those organizations that are participating in our training and outreach program account for 30% of the total number of fax referrals coming into South Carolina. So South Carolina, Dr. Wynn and her team have really worked on making sure that healthcare providers are aware of fax referrals. So there's a very robust fax referral program across the state, and our outreach program has had an impact by about 30% there. So, Rich, did you have the other slides along with those, or are those the only two? Oh, great, thanks. Yeah, so I'll just give you an idea of what I mean when I'm talking about the systems change training and outreach program for healthcare providers. As I said, we started in planning with the state of South Carolina in 2014, and then we actually launched the outreach in April of 2015. We're working with all counties in South Carolina. At first, we were prioritizing prenatal providers because the goal was to reduce infant mortality through reducing tobacco use with expectant mothers. And then we've also emphasized FQHCs and then the counties with high prevalence during pregnancy. And then the program has evolved, and now in the last 2 years, we are focusing on all medical providers and especially Medicaid providers. So we really want to also engage those systems that have adopted electronic referrals so that they are also doing a high quality referral. It's really easy to just click the refer. We know that our conversion rates are lower with electronic referrals, especially if providers aren't getting training on what to tell, how to prepare their patients. So we're focusing on that too. And then this is how the program works. We're offering technical assistance to really encourage providers to adopt the brief tobacco intervention into their daily practice. We have a 5-step curriculum, and then we also offer online training to support sustainability within the system so that they can train new hires, they can keep training their staff. The next slide. And this is just some of our outcomes from the last fiscal year. So almost getting close to about 919 or almost 1,000, I'm hoping that we can push for touch points, trainings, meetings, engagement with different tobacco champions, 342 different organizations or clinics or departments within hospital systems, 644 different contacts that we've engaged, and almost 200 providers trained. And I think that might be it on our slides. We've had some success. Here is our problem with what we're seeing, especially with those organizations that are not enrolled in our systems change program, is that almost 2,000 of those 2,475 fax referrals that we receive are participants that aren't getting services. They're either not reached or they're declining when we get a hold of them. So that really highlights our next slide. What the problem is how can we best engage providers to prioritize tobacco treatment, and then therefore so that they can prioritize it with their patients, and then how do we reduce that number of declined services and not reached from our referral outcomes? Those are hot topics. I know they've been asked before. We've talked about it a little bit, but this is what I would love to hear from our group.
That's great. Thanks, Kara. Those are great questions. Does anybody have any clarifying questions for Kara first before we dive into the discussion? Okay, great. So let's tackle the first question first, and then we'll move on to the second question. I'll watch time to try to get to both of them. Does anybody have something that they can share about how to best engage providers to prioritize tobacco treatment services amidst, I don't know, 1,000 or more competing priorities that providers are facing in their visits with patients? Any advice or experience you'd like to share with Kara?
It's Frank. I think we assume that all healthcare professionals at this point in the game in 2019 know that tobacco is negatively affecting almost every system of the body. But I found that it seems to me that it's mostly pulmonology, cancer, cardiology, the big major ones that really focus on cessation because it's obvious that the smoking is harming them, the patient. And people in other areas don't pay much attention to what the consequences are, even though we know very clearly that, from the eyes, the teeth, down to your toes, it's affecting you. So one of the effective mechanisms that I've seen used over the years is maybe doing grand rounds with in hospital systems and actually going into more of the health effects of smoking, the other health effects of smoking, other than just the major ones, to make it very obvious and apparent to all the other professions that they're being touched, they're being affected, their patients are being negatively affected by smoking, even though it may not be as apparent as someone who has lung cancer or had a heart attack.
So this is Steve. In other attempts to change clinician behavior, sometimes competition is effective. And if you could array the continuum of best to worst, and then highlight for the individual without letting everybody else know, but highlight to the clinic that you're aiming at where they fall along that continuum, there may be an impulse to try to do better. So if there's a way that you can do a systematized version of competition, you might find that that's helpful.
That's great advice, Steve. Yeah, friendly competition can sometimes make a big difference. Yeah, and even seeing not just the competition, but I think sometimes people don't recognize that it's possible to do better, but then they see like another county or another health center nearby or similar to them that's doing better, and it can be kind of inspiring too. I've seen that too. How about any of our health centers have any experience about things that have worked for you to encourage your providers to spend more time on tobacco treatment?
This is Carla from Lancaster Health Center. And one small area we're trying to impact is often our clinical support staff are responsible for the screening. And so then providers would obviously be responsible for the counseling. And we found a bit of a break between the transfer of knowledge from the clinical support staff to providers. And so are implementing a new workflow where providers will add that ICD-10 code every visit for patients who have tobacco dependence. And that just pulls it to the forefront of the assessment and plan there and has it on the problem list. And that just, I mean, like we heard today, multiple quit attempts, that just pulls it up in every visit to the forefront of the provider's mind. And we're hoping that will really bridge that gap and really help the prioritization of, those brief tobacco interventions each visit.
That's cool. So then, does that then, so the ICD-10 code, does it show up on the patient's after visit summary too then?
So yes, it can, and we then have procedure templates built that the provider can pull in based on seeing that ICD-10 code that kind of lays out the things to touch on in counseling. and they can attach patient information, education information as well for follow-up. So then there are a few options for follow-up based on that trigger of seeing the problem right up at the top of the assessment plan.
Great, thanks. Yeah, that's an interesting one, and I love that. I mean, as a provider myself, like if it's there in front of me, then I have to sort of do something with it. So it kind of forces me to like think about it, even if I'm not going to address it in that moment, because maybe I just saw the patient a week ago and we talked about it then. But maybe it's been a while and I haven't talked to the patient about it. It at least prompts to help me remember to address it. And then if the patient sees it, at least if it shows up on their like diagnosis codes on their after visit summary, if they keep seeing it, maybe the patient will get engaged at some point or empowered and ask like, hey, doc, you haven't talked to me about this in, you know, however long, and why is it still on my list, or something like that. So that's kind of a cool, I like that. That's great. For time, I'm going to move us on, but if you have something else to say on this, just interrupt. I'm going to move us on to the second question so we get to that too. So Kara and South Carolina are interested in learning about how they can reduce the number of either declined services or the not reached. So once a good referral is made, then either patients say like, oh no, thanks, I'm not interested, how to fix that, and then also how to fix the ongoing challenge of not having accurate contact information for patients and not being able to reach them. So any tips or advice, even if this is from this could be the health center might have advice on this, or the housing authorities. I don't know if you have thoughts on how to help patients or your residents either with their contact information or help educate them more about the value of Quitline services.
Kara, this is Frank. So I have two very specific questions that you can ask people who are declining service. So almost, I would guess most people are saying something, some variation of I'm not ready. So what I say to somebody who tells me that is, how can I help you get ready? So obviously I don't know what your Quitline counselors are specifically saying, but if they're saying, oh, okay, then we'll contact you in a couple of months or whatever, don't say that, just go right in. How can I help you get ready? But even more importantly, Karen Hudman at Purdue, she says this all the time to her patients who are in this specific position, and it works brilliantly. So the question is, how would it benefit you to quit booking 6 months from now rather than today? I know that may be an odd kind of question to ask, but it really throws the person and they really have to think about it, because that kind of, it's a motivational interviewing type question, and it kind of forces them to think, well, yeah, there is no real benefit for me to wait 6 months or a year, and it would actually be better for me to quit today. So I would ask the question that way. How would it benefit you to wait? How would it benefit you to wait 6 months or whatever the person's telling you? And hopefully that will maybe help flip them around a bit to think about this a little differently and engage in quitting now.
Thank you.
Anybody else? That's helpful, Frank. Thank you. Anybody else have thoughts on the reducing the number of declined services or the not reached?
Yeah, this is Amy. Just a couple of suggestions. We're facing those same issues. We're actually doing a study in 2020, more of an implementation follow-up study from 2 systems that have integrated e-referral to the Quitline system-wide, and really just doing some qualitative interviews of staff, figuring out what they're doing, how they're doing things, education that they're sharing with patients. So hopefully we'll learn from that study. But currently we're just trying to make sure that education is there. You mentioned this quality referral, so that's a huge key point, making sure that the patients are truly interested in being referred, really vetting them to make sure that that's going to be a quality referral. But then the education side, making sure that they know, caller ID issues with the Quitline, when to expect those calls, coming within, the 72 hours, whatever that may be. Even going as far as, old school paper handouts, giving them that information, having that populate into the after visit summary. I'm really treating those calls that they'll receive from the Quitline as an appointment themselves. So giving reminder calls, reminder handout cards, letting them know, again, that Quitline information. So just trying to give them all of the reminders and education on that. So hopefully they're likely to pick up the call. And if you can find out those best times to call, making sure that those are accurate, and that those patients know that those calls ideally will be coming in around those times that they stated would work best as well. If we're thinking kind of longer term, if we can make changes, ideally having the Quitline with the universal name or number that would show up on caller ID. So we're hoping that that might be possible sometime in the future, or even having the Quitline texting before they call. I know that's really out there. That would be challenging, but things that can come from the Quitline that would make those patients more likely to pick up the phone. But keep trying to do whatever we can do.